Good morning, everybody. 50% of my talk covered by Dr. Rajiv. So I think I have to skip few of the... When I was there in a postgraduate from SAB Medical College, which is a government medical college, huge rush of patients. First thing, any patient comes with chest pain and ST elevation, first put the oxygen, because a government hospital, we have to immediately put the oxygen. Started with that. Then when I entered my diploma cardiology from NIMS, then I started, my professor Sai Shankar sir told, no, first you read the Brown world. At that time only recently it came. Avoid oxygen in a patient with acute myocardial infarction unless until some indications are there. So oxygen therapy is suspected in myocardial infarction. No benefit with supplementation oxygen if saturation is above 92% in acute MI or suspected MI. So this is what the ambient oxygen and oxygen, if you give oxygen, that is harmful to the acute MI. The summary is oxygen administration, class 1 indication if the saturation is less than 90. This is the indication. Second, how my practice has been changed because of these trials. Management of perioperative bridging anticoagulation in patient fibrillation. So what I did before, perioperative management of anticoagulation is challenging, as a physician must consider the risk of stroke, systemic embolization and perioperative bleeding. Prior to bridge trial, perioperative bridging anticoagulation in patient with requiring interruption of the warfarin remain unclear. Whether to stop warfarin perioperative or before operation, it's not clear. Now this bridge trial very clearly shows that if you stop warfarin, and if you start low molecular weight heparin, minor to low risk bleeding procedure, 12 to 24 post-operatively you can start again, stop it 5 days before warfarin, and low molecular weight heparin begin 3 days pre-op, and in a minor to low risk 12 to 24 hours you start it, and low molecular weight heparin continued until INR is more than 2, you can overlap. So that is what the bridge trial shows, that it shows primary outcome and secondary outcome. If you give low molecular weight heparin, it's beneficial. So should we start perioperative high dose of beta blocker? This is the third trial which everybody has talked about beta blocker. Now the beta blocker, one of the trials shows that high dose of beta blocker is good or bad. They have compared intervention of metoprolol versus placebo, given 100 milligram 2 to 4 hours pre-operatively and 6 hours after surgery, and day after surgery 30 days patient received 200 milligram of steady dose. Dose decreased to 100 milligram daily if the patient become hypotensive or bradycardia. This is guidelines in AHA guidelines and ESC guidelines, where vascular surgery and ischemia or pre-operating testing, vascular surgeries, more than one risk factor, vascular surgery with established coronary artery disease. Previously it was class 1 indication, which became in 2009 it is class 2A indication, where it become in ESC guideline established coronary artery disease or ischemic or pre-operative stress testing class 1 indication, high risk surgery class 1 indication, intermediate risk surgery class 2A indication. So what happens if you give high dose of metoprolol? It shows that 1 year cause of mortality is high. 1 year non-CV mortality is high compared to placebo. 1 year stroke is also high as compared to placebo. So versus metoprolol group versus the placebo group, all this non-fatal myocardial infarction, non-fatal stroke, all these things are higher in high dose of metoprolol. The implication or the conclusion, POISE results suggest 1 year, every 1,000 patients having non-cardiac surgery, metoprolol CR would prevent 12 patients from experiencing the myocardial infarction, from 6 from undergoing cardiac revascularization, but result in excess 13 deaths and 6 strokes. So the conclusion is, don't start high dose of beta blocker just before non-cardiac surgery. So perioperative beta blocker for non-cardiac surgery increased death, stroke at 1 year. This is what the recent POISE study. Fourth one is mineral MRA in heart failure with preserved ejection fraction. Lot of study has been done for MRA, is one of the gold standard for the heart failure with reduced ejection fraction. I am not talking about reduced ejection fraction, this is the preserved ejection fraction. 2 trials which has really changed actually for the heart failure with preserved ejection fraction. even ACE inhibitor, ARBs is not that much of effective as heart failure with reduced ejection fraction. So what I did before with the CHF CHARM study and iPreserve trial evaluate ACE inhibitor and ARB in the management of heart failure with preserved ejection fraction, identified no mortality reduction but fewer hospitalization. It is little bit better but no mortality reduction. In optimized heart failure registry, beta blocker clearly shows that very ineffective in reducing mortality and hospitalization in patient with preserved ejection fraction, heart failure with preserved ejection fraction. Therefore, the current guideline offer no specific recommendation for the treatment of heart failure for preserved ejection fraction. So now the recent trials like TopCat and ELDOS DHF trial, which very clearly shows that new insight into the role of MRA in the management of heart failure with the preserved ejection fraction. Heart failure with preserved ejection fraction are unlikely benefited from the beta blocker, ACE inhibitor or ARBs, but these two trials demonstrate improvement in the diastolic function, reduced hospitalization in those treated with spironolactone with no effect on cardiovascular mortality in primary analysis. This is the TopCat study where they have analyzed placebo versus spironolactone group. All the primary outcome, cardiovascular mortality, absorbed cardiac arrest and heart failure hospitalization, everything is reduced with spironolactone group. So what I do now, of course MRA is a very gold standard for the heart failure with reduced, not only for reduced ejection fraction, these two trials which clearly shows that it is a very good drug for the heart failure with preserved ejection fraction. Fifth one, continuous versus bolus intermittent loop diuretics infusion in acute decompensated heart failure. When I was doing my post-graduation in cardiology also, we used to start with, if a patient comes with acute pulmonary edema, with a frank pulmonary edema, high dose of Lasix, high dose, then followed by infusion of Lasix. This is what the management of acute decompensated heart failure in typically through the administration of loop diuretics including furosemide, then after that torsemide or budotamide. Patient admitted with heart failure, acute heart failure received low to moderate dose intravenous diuretics which may have prolonged their symptoms and hospitalization compared to high dose. So what changed my practice? This is the dose study, dose trial, which comparing intravenous low dose versus intravenous high dose loop diuretics and intermittent bolus also with continuous infusion. They have compared. Overall, no significant difference among all the groups. Patient symptoms, creatinine, high dose group had greater diuresis when transient increase in creatinine. So if you give high dose of Lasix with a continuous infusion of Lasix, definitely the creatinine value will increase. This is what the proportion of worsening renal function, high versus low dose. It very clearly shows that high dose if you give the worsening of renal function and rise of creatinine. Death, rehospitalization and the hospitalization, the continuous versus the high dose versus the low dose, definitely high dose has got higher mortality, higher hospitalization. And the conclusion is there is no statistically significant difference in global symptoms, relief or change in renal function at 72 hours or either. The bolus versus the continuous infusion, low intensity versus the high intensity. The conclusion is there is no evidence of benefit of continuous infusion compared with bolus, means the dose QID, TID or BID dose on the secondary endpoint. Despite transient change in renal function, there is no evidence of secondary risk of clinical event 60 days associated with the high intensity strategies. So high intensification like 2.5 into oral dose was associated with trend towards the greater improvement in the multiple domain. Like if you give high dose, symptoms relief will be there, weight loss and net volume loss, proportion of free from sign of congestion and reduced NT-proBNP. What I do now, there is no significant difference between the intravenous low dose versus the high dose with respect to efficacy and safety. The equivocal result between the bolus and the continuous infusion suggests no significant advantage to either route. We do not recommend routine infusion of loop diuretics as there is no benefit. This is the sixth one, myocardial infarction in women without obstructive coronary disease. One of my sister, actually 29 years, she came with chest pain. We did the ECG, shows that extensive ST elevation, acute ST elevation MI. But this is what I did before. Women with myocardial infarction with a twofold higher rate of non-obstructive coronary artery disease, defined less than 50% stenosis in angiogram. In past, etiology of myocardial infarction in these women were unclear. As such, it was my practice that many other cardiologists to offer reassurance to women with myocardial infarction in spite of ST elevation in ECG, in spite of after getting the angiogram report where the non-significant coronary artery, only left is few drugs and reassurance. Presumably we may think that it is because of vasospasm. Now what changed my practice? This few of the trials published in Circulation investigating the mechanism of myocardial in women without obstructive coronary artery disease. Conclusion was the plaque rupture is a common cause of myocardial infarction with non-obstructive CAD among women. Further, in women with the CMRI abnormality with no plaque disruption in IVUS, vasospasm, embolism or mixed spontaneous coronary artery dissection may be the potential etiology in women with myocardial infarction. The plaque rupture is common in myocardial infarction in women without obstructive coronary artery disease, as may occur in angiographically normal segment. So this is what IVUS should be considered at the time of angiography, particularly among the patient with localizing feature of ECG. CMRI could be considered to look for the ischemic late gadolinium enhancement or T2 signal hypersensitivity, and often still present months after the event. I routinely consider statin and aspirin in patients without obstructive coronary artery disease, particularly in those with mild luminal irregularities. I strive to determine the etiology of myocardial infarction in women with prognosis and management may vary widely, and spontaneous coronary artery dissection is often missed on initial review of the angiogram. So I prefer to go again and again, see whether I have missed anything in angiogram. Sixth one, rivaroxaban for the thromboprophylaxis after hospitalization of medical illness. Medically ill patients who were increased risk of venous thromboembolism, improved score of 4 or higher, or the score of 2 or 3 plus plasma D-dimer more than twice upper limit. This is they have taken as a category, and at hospital discharge to either once daily rivaroxaban at the dose of 10 milligram or placebo for 45 days they have given. The conclusion of this trial, rivaroxaban did not significantly reduce the composite symptomatic thromboembolism or VTE related death in at-risk medically ill population post-hospital discharge. Secondary outcome revealed 56% reduction in symptomatic VTE and 27% reduction in symptomatic VTE. And the rivaroxaban 10 milligram in subject without significant renal impairment appeared more effective than reduced dose of subject in moderate renal impairment. The incidence of major bleeding with rivaroxaban was low, with no significant increase in major clinical fatal bleeding. So we believe there is a filling pathway forward approval. So what I do now, rivaroxaban given to medical patient with a high risk, improved score more than 6 or 2 to 3 women for 45 days after hospital discharge for a high risk group, was not associated with significantly low risk of symptomatic venous thromboembolism and death due to venous thromboembolism than placebo. So the role of rivaroxaban also negative versus placebo.